Welcome everyone to today's webinar. I'm Molly Gamble with Becker's Hospital Review. We will begin today's webinar with a presentation and panel discussion, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We're looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. Our webinar today is Analytics of Behavioral Health in the Emergency Department, Benefits of Telepsychiatry, and will be presented by SOC Telemed, the new name for Specialists on Call. SOC Telemed is the largest provider of telemedicine technology and solutions to U.S. acute care hospitals and health systems. Let me introduce our two presenters. Dr. Till Jolly, Chief Medical Officer, is a board-certified emergency physician with more than 20 years of experience practicing at both George Washington University Hospital and Inova Fairfax Hospital. Hai Tran, Chief Operating Officer, has helped build a broad range of public and private high-growth healthcare companies such as BioScript, Harris Healthcare Solutions, and Catalyst Health Solutions. At this time, I'm pleased to turn the floor over to Dr. Jolly to begin today's presentation.
Thank you very much. And today, we're going to talk with you a bit about a problem that's large and vexing for many healthcare systems and many individual providers all around the country, and that's the behavioral health problem that we all face as clinicians and hospital administrators and providers. If we could move to the agenda slide, we're going to go over a number of areas today, and we're also going to have time to take your questions and do a little interactive polling and sort of so everybody can see what your various thoughts are on the problems at hand today. As you can see from the agenda, there are challenges for mental health in the emergency department. That's not a surprise to anyone who has been in the emergency department any time in the recent past. But really the challenges also are beyond the clinical challenges, but it's a financial challenge and a cost challenge and an opportunity challenge for your facilities. We're going to talk specifically about telepsychiatry. Telepsychiatry is really just psychiatry delivered by another method. There's nothing particularly mysterious about it or exotic, but it's a way of getting a provider, not necessarily a psychiatrist, but a provider in front of a patient in need at the time and place they need it. This is appropriate for both adults and children, and patients across the continuum, both the most severely affected patients by psychiatric illness, and then those that perhaps have ongoing needs. And then at the end, we'll have, as I said, time for a few conclusions and your own action plan and a little Q&A. We can go to the next slide, please. So challenges. We all face challenges, and many of you are aware of the framework promulgated by the IHI as the triple aim. When we look at healthcare problems, we really look at the triple aim as a framework for defining the problems we face and then the potential solutions for those problems. The triple aim, as you know, relates to population health, the experience of care, and the per capita cost around whatever the healthcare problem may be. In this case, the problems are well known. Mental health is a huge challenge in this country, a growing need, an access problem, and there have been many, many societal changes over the last several decades that have perhaps worsened this problem. But that's really a time for another discussion. It's really a matter of how do we address the problem today. Those patients are severely disabled and face challenges in finding acute care and ongoing care. And then those patients have a poor experience of care. They wait prolonged periods of time to find any help they can, if they can in fact find help in their locality. They may wait for an outpatient provider, and certainly when they approach our emergency departments in our hospitals, they wait for the appropriate provider for an inordinate period of time. It's well known that mental health patients can wait at least 3 times longer than other patients for care, and may board in the emergency department for anywhere from 8 to 34 hours, and 34 is actually optimistic in many hospitals. It can be much longer, as you know. But it's all well and good for us as clinicians to talk about this from a purely clinical standpoint, in a sense, in a manner of thinking about right and wrong, but there are costs involved, and we have to work with our administrators, our financial officers, and others to really find the best and most cost-effective way to take care of these patients where waiting costs can top over $2,000 based on bed availability, and the reimbursement is much less, as we know, in mental health. But then the cost of care and the opportunity costs related to the capacity needs of certain hospitals and their inability to take care of other patients because of boarding of psychiatric patients are a critical issue. If we could go to the next slide, what we're going to do now is we're going to put up an interactive poll that you're going to be able to go through, and you'll have the opportunity to answer these. I'm just going to go over the potential, the questions and answers, and sort of get a sense of the audience and what sort of problems you face. So, very simple. Which of the following has your organization done to meet these challenges? And they're really the challenges of mental health. And you can broadly define mental health in your own way. Created a separate area of the emergency department for mental health patients, hired locums tenens psychiatrists, hired additional security, or partnered with law enforcement, paramedics, social services, and or placement facilities to streamline care. All of those are potential answers. Please go to the Q&A now, and we'll give you a few seconds to answer. Okay, I'm going to ask, if I could, our facilitator to read out the answers that have been placed or set them up. Do we have that? There we go. So, interestingly, there's really a mix. There's really a mix. Thank you. There's really a mix of answers that we see, and really some of these. This is really a question of how do you take your space and your staff and your resources and apply them. And you see the mix across creating a separate area of the emergency department, to partnering with local services, partnering with law enforcement who have a key role to play in the management of behavioral health patients, hiring additional security, and then hiring extra staff. All those are answers for potential question. I don't think any one of them answer the question, but all of you clearly face these issues. If we could move on to the next slide. So as we look through the costs, thank you. As we look through the costs, there are truly financial aspects to this problem. And now I'm going to turn it over to Hai Tran to talk through some of the costs of treatment for these patients. Hai?
Great. Thank you, Till. And maybe we can go to the next slide as a framework. So one of the things that we do is we currently provide telepsychiatry solutions on a national basis with a wide variety of hospitals in a wide variety of settings, whether those be academic, medical centers, or large urban areas, or rural markets, or community hospitals. And across the board, some common themes arise with regards to the challenges around behavioral health. And so when we think about those common themes, we put them in this type of a framework around what the hospital challenges are, broadly speaking, what those impacts may be, and then how telepsychiatry might be helpful. And so when you think about the hospital challenges, and I saw from the quick poll there that a number of the audience members here are engaging in locums, and that is, not surprisingly, an expensive strategy to assist with the volume of psychiatric patients. There are clearly some boarding costs as well. And when we think about boarding costs, these are not theoretical costs. If you look at those elements that I've put underneath boarding here, whether those be additional nursing hours, sitter fees or security costs, these are what I call variable costs. There are a lot of studies out there that think through kind of the operational cost per hour. But point in fact, when I think about it practically, if there was a mechanism to increase the throughput, some of those operational costs are point of fact fixed costs that really can't be eliminated. So here, when we're talking about some of the boarding costs, I'm really talking about true variable costs or true direct costs associated with extended length of stay or extended boarding for those behavioral health patients. There's also an impact to revenue, and mostly around opportunity costs. And then lastly, there are other operational issues or patient satisfaction issues, given the ripple effect of an ED that is overburdened by behavioral health patients, whether those be staff safety issues or retention issues, because it is very common for us to engage a hospital whereby they have limited on-premise resources that are just being burned out due to the lack of backup, and they need a solution to enhance that provider retention, or extended wait times associated with other patients in the ED as well. So when we look at through this framework, telepsychiatry, has, at least in our eyes, proven to be a pretty useful tool for hospitals to employ to solve some of those challenges and those issues. From a locums perspective, what telepsychiatry does provide is the ability to put in place a 24/7 coverage model, or even a partial coverage model, depending on how you're deploying the locums today, and at a much less costly price point. But the reason for that is because the ability to fractionalize the cost of one board-certified psychiatrist across multiple facilities, and so multiple facilities are sharing in that cost, and that ability to fractionalize that cost enables telepsychiatry to be a very cost-effective tool for coverage. But even more importantly, one of the most interesting things about telemedicine is the ability to grab a lot of data and really drive standardized clinical protocols. And with that data, provide some meaningful insight and continuous improvements on what protocols really work, what components of workflow really are driving the results, the desired results, whether those be clinical results or operational results. There's a lot of data and insights that really help. With a locums model, that's more difficult, at least from our dialogue with many of your peers. On the boarding side, right, there's a couple ways that telepsychiatry can help. If you find the right telepsychiatry partner, one of the biggest ways that they can help is increasing the discharge rates. A lot of times, in our experience at least, when we become engaged with a hospital, oftentimes we're able to double the discharge rates in a safe and effective manner. And what we attribute that to is just experience. On average, our psychiatrists might be are clearly licensed in more than 10 states and have privileges in dozens of hospitals. And so, when they are, on shift, they see a lot of patients, and it's that repetition that builds that institutional skill set and knowledge. And so they're very quickly able to identify which patients are truly a potential harm to themselves or others versus which ones are not. And it's that experience that enables a very high discharge rate in a safe and effective manner. And so the right telepsychiatry partner can meaningfully improve throughput that way. And that throughput does translate directly to cost reductions. If you look at the ability to free up available beds, potentially directly reducing sitter fees or security costs, or to the extent there are marginal additional nursing hours that were scheduled. And if you think about that discharge time, that's not dependent on placement. What happens on the placement side. That is truly a direct impact to throughput. The second way a telepsychiatry program can impact positively a program or the ED is the ability to see a psychiatrist fairly quickly, right? So if you look at, when we engage in conversations with ED departments across the country, as Phil mentioned, many of them are telling us, the average wait time to even see a board-certified psychiatrist, 8, 10, 12, and plus hours. And that's fairly common, right? Most telepsychiatry programs, are able to see a patient within an hour, within 2 hours, 3 hours. So the difference between, the 2 hours or the 12 hours, that 10-hour difference is true cost savings. But there's a caveat to that. The caveat is that most telepsychiatry programs, are not solving for placement. So to the extent that they're, they can see the patient faster, but there's nowhere to place that patient, right? The average length of stay still remains the same. If there is a robust program for placement of the patient, then telepsychiatry is a very useful tool for driving the throughput and increasing efficiency and driving down costs. The other, and then when we move down to the revenue piece, from a revenue perspective, this also depends, very much like the placement conversation. It depends a lot on what we, a real estate term, occupancy rates, right? What is the level of, what's the average level of occupancy within the ED? If it's a high level of occupancy, that would tend to suggest a high opportunity cost. And so to the extent that, we can drive up throughput, for these patients, that's an opportunity for hospitals and ED departments to fill the beds with patients that that are more billable from a business model perspective than a psychiatry patient may be in the ED. And then the last thing we talked about it, and this happens all the time. I touched upon it. There are psychiatrists are increasingly difficult to find and recruit, and more importantly, very difficult to retain if the organization is not somehow supporting that psychiatrist so that they can manage that balance between the professional and the personal life. And so we've engaged many hospitals in those types of discussions, and typically those are very much a real concern for those hospitals, as well as the staff safety and the patient satisfaction in the ED as well. So generally, that's kind of the framework that we engage in a dialogue with many folks across the country, and it resonates time and time again that these are the ways that many hospitals are looking at the benefits of the impacts of the challenges of behavioral health patients and how telepsychiatry can help. If we go to the next few pages, what we're going to do here is, one of the things that that we like to do is really, in order to measure the benefits of telepsychiatry, as opposed to the anecdotal conversation on telepsychiatry, we spend a lot of time with our clients trying to help them gather some baseline information. In fact, we encourage folks to gather the baseline information as part of our initial conversation, whether they decide to engage us formally or not, because it's that baseline information that will help drive the ROI for the programs, right? So for the, first of all, what's the volume? What's the anticipated volume? Simple question. Being able to really understand that number is incredibly useful as a baseline, right? And how does it fluctuate? Are there seasonality? Are there specific times of the day? Because that helps you think through what type of program you want to engage in from a telepsychiatry perspective, even if that telepsychiatry program is one whereby you are standing up a program and utilizing your own psychiatrist within your own system, right? So when we have those conversations whereby healthcare organizations are looking just to utilize our platform but utilizing their own clinicians, these are the conversations we have all the time, right? How do we provision and schedule those providers appropriately? Are there trends within the day, within the week, within the month, within the year that help us apply some predictive models and essentially appropriately schedule those physicians for care? You go to the next page. Another question that we ask, is how long, right? What is the average length of stay? And then we try to drive down and really understand and help our partners understand, is the length of stay truly because they're not able to get access to a board certified psychiatrist, or is it a placement issue, right? Because as I mentioned previously, we and other telepsychiatry organizations, or even within their own organization, they can help with the speed to which we can see the patient. They can help with the discharge rates, but placement is a different initiative that organizations have to take on. When we go to the next page, what we see here is, we talked about boarding already, right? You know, and this is about understanding the numbers, right? So we tried to spend some time with the administration, with a finance organization to see what data they have, and can we be helpful in terms of parsing out what's truly a variable cost that can be reduced to the extent that telepsychiatry is implemented within that organization, or what is a fixed cost that theoretically, might sound nice, but in practice aren't costs that you can really get at. On the next page, when we look at wait time, right, for other ED patients, this is something increasingly a lot of folks are really taking a hard look at, but it depends on the hospital, right, from that or the facility. In certain facilities, the wait time is not an issue, but I would say that's the minority. The vast majority of wait times are, if not an issue, at least a concern or a focus area. And so folks are spending time here making sure that to the extent there are spikes in volume from behavioral health patients, they're not adverse ripple effects for the other patient population as well. On the next page, the conversation we'll enter into is, around security and sitter fees, right? And as you can see here, the incidences around security issues are more common than we'd like to think, unfortunately. And so these are, and when they happen, they're quite intense and quite emotional. And so, clearly, being able to reduce the time of which a patient has to wait for a psychiatrist for the evaluation is incredibly helpful in this regard. And to the extent we can increase the discharge rate, it's incredibly helpful in this regard as well. On the next slide, when we're looking at recruiting, we've touched upon this several times. We can tell you personally and our own experience that within our various specialty lines, the labor inflation for psychiatry is outstrips any other specialty that we've been involved with. So it's getting not only increasingly difficult to be able to recruit and hire psychiatrists, it's getting increasingly expensive as well. And so the ability to employ a model that takes advantage of a good psychiatrist in terms of making them as productive as possible, taking advantage of every hour to deploy them across a broader geography is a great solution. And then on the next page, we do spend time. This is a softer conversation around satisfaction. But, you talk to and we have these stories all the time, when we talk to the nursing staff in particular, there is the sense of in every ED that we're involved with, and the reason people in healthcare is that sense of obligation to provide the best patient care possible. And when we talk to some of the nursing staff, they're fairly frustrated, right, that a patient has to sit in a hallway or sit somewhere and they can't really do anything for that patient for hours on end, right? And so when we're able to help with that, see that patient more quickly even, that level of frustration on the staff, does decrease in a significant manner. And then lastly, here we have, and last on the next page, we have another interactive poll that we'd love for you all to provide us some input into, very similar to what the first one we did. The one point I'd make, and just got back to the results from the first poll, was that many of you are looking to set aside a portion of the ED to handle the behavioral health patients. That's an interesting model. In fact, increasingly, we're working with a number of our partners to create observation units and perform what's characterized as crisis stabilization, because there's a different reimbursement model that is more attractive, that enables a more structured approach towards caring for those behavioral health patients in a separate part of the ED as well. So those are things that we're always exploring. The model is changing and evolving. And so it's great that folks are already thinking about that as well. So here for the interactive poll, you know, we're looking for kind of, you know, what are your biggest hurdles, right? You know, and data not being available, for example, is something that we hear quite a bit, or they're in disparate places, and it's tough to try to consolidate that data. Resources, clearly, always a challenge, and that's what we can absolutely be helpful. And lack of insight to best practice as well. But once again, you find the right partner, they've got the experience, they will provide you those insights. So with that said, if you can take the next 20 to 30 seconds to respond, and then we'll flash the results. Fantastic. That is not a surprise to me. We hear that probably the most. Data is clearly available. It's not organized in great in a manner that's easy to get to, and so this is not a surprise. However, I will say that there's a saying I have, which is the juice is worth the squeeze. It is absolutely worth it to go and hunt down the data, as difficult as it is. If you engage the right partner, so for example, with us, we have a team that will help organizations perform ROI modeling, with no obligation. So we'll be very, we can be fairly consultative, and there are others out there that can be helpful as well. But you find the right partner, they can help you, not so much hunt down the data, but once you gather the data, they can definitely provide you some analysis based on their experiences, as well as insights to some of the best practices out there and what we're seeing in the marketplace. All right. So with that said, I think that the next section is on the next slide here. I'm going to turn it back over to Dr. Jolly. Till is going to review a number of real life examples we have and some of the benefits that we've seen when we've engaged our partners. Till?
Thank you. What I'm going to do next, and if we could go to the next slide, what I'm going to do next is go through some real life examples, and they can be characterized as anecdotes, and as we all know, data is not the plural of anecdote, but these are important examples, and those of you who work in and around hospitals, which is probably the vast majority of people on this call, and thank you again for your time on this, are not going to be surprised by these. The scale of the problem or the version of the problem you face is not going to surprise you, and many of you have gotten probably frustrated with the societal problems that have driven some of that. You should know that there are a number of both medical and not-for-profit organizations that are advocating based on these sorts of examples to really work with that, and I encourage you in your communities to work with those organizations to try to drive change. One example that we have seen, and this is a true example, but a bit de-identified, medium-sized emergency department, 45,000 visits, not the busiest, but not the smallest either. Seeing 2 or 3 child or adolescent patients a day. Not really a huge volume compared to all the patients they are seeing during the day, but anxiety provoking. There are families involved, and in this case, and in many cases, this hospital doesn't have a psychiatrist who is willing and or able to see a child or adolescent. And where that becomes a problem is with the emergency department staff or the social work staff is capable of assessing perhaps whether that patient should be admitted by some fairly broad criteria, that there are not available beds in the community for that patient to go to an inpatient unit, so they stay in the emergency department, sometimes for 5 to 6 days. There are multiple problems in that. One, they've not been evaluated by a subspecialist who could really make an assessment about their acute needs and whether they are in crisis or not, and whether they can be appropriately managed in some outpatient setting. That is nothing against the emergency department staff or the social work staff, but it's not necessarily their level of expertise. Assuming they even need to be admitted, those patients are not going to be managed as actively and with as much skill and ongoing oversight in that emergency department, just based on the way that emergency departments work. Very shift-based work, focused on crises, not necessarily focused on patients who stay there for days and days and days. And in fact, those patients, were they appropriately managed over a period of 3 to 4 days, might be stabilized to the point that they wouldn't even need the bed anymore. So, you know, the far end problem might be just create more child and adolescent inpatient beds, but that is not going to happen. So this is where telepsychiatry, with a bent toward child and adolescent psychiatry, and plenty of general psychiatrists can see children and adolescents in crisis and help to assess them. There's not a magical cutoff at age 18. These patients could be better cared for in a manner that they would be comfortable with, the families are comfortable with, and the emergency physicians and other staff are comfortable with. And then there's a financial and operational benefit on the far end, because faster disposition, less danger to the staff, leads to more open beds, better throughput, and greater staff satisfaction. So that's a real life issue. You may work in hospitals that face that sort of issue. This is not unique to a particular state or a particular region of the country, but it's something that is quite anxiety producing among staff, family, and providers, and is a real issue. And telepsychiatry is a perfectly reasonable option to solve this in a manner that really suits the patient best. If we go to the next slide. Medical clearance. So medical clearance is an interesting term. Patients that come to the emergency, for those of you who don't know, most of you probably do, patients come to the emergency department in some sort of psychiatric crisis. And beyond just the acute stabilization, the management of their anxiety or their agitation, there's a concern that perhaps this illness has a medical cause, whether that cause be infection or some metabolic disorder or an endocrine disorder or a substance abuse disorder, which is often the case. It is incumbent upon the staff to clear those patients. However, once they are cleared, the emergency department staff and others that are involved in that clearance really have done most of what they're going to do. We have run across this example, a large tertiary care center that sees over 100,000 patients, a big, busy emergency department that also has a lot of inbound traffic from other referring hospitals, where, in fact, their crisis is so bad that 27% of their bed hours are taken up by patients who have been medically cleared, but are waiting for psychiatric disposition. And this is where data can help, because this department analyzed their data and then began to develop a strategy that included telepsychiatry and on-site psychiatry in a logical way to manage this problem. This is a data-driven solution, and this is the sort of data that this emergency department can take to its hospital administration with real numbers and real downstream effects to try to affect change. This is a large example. You may not work in a hospital where the example is this great, but it is a real example and is an outgrowth of the way that that services are made available in the outpatient environment for many of these patients. Next slide. Thank you. And then probably the issue that Ty mentioned related to crisis stabilization is really tied in this slide. As we know, in the emergency department, many patients come in under the influence of some intoxicant, whether it is alcohol or an opiate or cocaine or meth or some other intoxicant. They frequently are agitated, dangerous, unstable, and need to be managed acutely. Now, that is well within the purview of the typical emergency physician and emergency department, in fact, EMS and police to manage. However, those patients frequently make threats of self-harm or harm to others in that intoxicated state. A very traditional, very rote method of managing those patients is to take those patients, take those statements as fact, and attempt to provide a disposition for those patients because they are at risk to themselves. As we know from experience, from personal experience of practice and from experience in our hospitals, those patients stabilize over time. Once their agitation is managed, they metabolize whatever substances in their body, and usually a period of 6 to 8 to 10 hours, they sometimes don't make those statements. Now, the fact is, in an emergency medicine setting and in a hospital setting, the management of those patients on an ongoing basis becomes difficult because that emergency department, if all the patients are joined up together, isn't really set up to manage those patients and reassess them well at 10 hours. Different hospitals have different ways of managing this. Some set aside a separate part of their emergency department as a psychiatric holding area. Some, in fact, set up an observation area purely for psychiatric patients. Now, a physical space is nice. The physical space is important, but that physical space has to be staffed appropriately with an operational framework and with staff who really understand that patient population and can manage them. And one of the terms in the industry is crisis stabilization. There are others, but essentially it recognizes facts of physiology and behavior that replicate themselves. And so rather than subjecting those patients to inpatient beds, putting them in a place that is designed for them in a specific way offloads things from the emergency department from the rest of the population and really manages those patients in a way that perhaps in many cases up to 40, 50, 60% may result in an appropriate discharge for that patient rather than an admission to an inpatient bed where ultimately the outcome will be a relatively rapid discharge because of the stabilization is recognized by a psychiatric specialist. Lots of benefits, safety, freeing up beds, and boarding costs being lowered, and really, bottom line, better care for the patient. It's really what the patient needs. We would like to solve these problems societally, but the fact is these problems are going to continue to happen depending on the drug of choice in a locality, and recognizing that telepsychiatry is a clear option to assist the local staff in making an ultimate disposition decision regarding that patient. If we can move to the next slide, please. And then probably the most common setting in which we come in a very concrete way is the setting related to involuntary commitment. As you know, there is significant state to state and sometimes county to county variability in the rules and regulations relating to involuntary commitment. And these change over time depending on legislative and societal priorities. But fundamentally, someone in the community, either family, law enforcement, or someone else, decides and declares that based on behavior, that patient represents a threat of self-harm. And then they present to the emergency department. This is a difficult decision to make for someone who is not trained in the risk inherent in a patient's statement of self-harm. These are tough situations. These are tough calls. And one has to put the statements of self-harm into context and decide whether they are simply gestures or real threats of self-harm, and whether a patient can contract for safety, as the term goes, to provide for safe care out in either the home or some other supervised environment. In some cases, in some states, it is mandated that a psychiatrist be the one to provide those judgments. And in fact, ours, along with many other services, began really to address this problem. Hospitals with patients boarding where someone had decided, probably in very good judgment, that that person was unstable, presented a threat to himself or others, and brought them to medical care, which was not necessarily set up to manage them. And then those patients board for days waiting for a psychiatrist, not being medicated, not being managed appropriately, only really being watched by security and the staff until some sort of disposition is hopefully made. Shortages of psychiatrists and psychiatrist beds make this worse, and this is sort of the textbook situation where telepsychiatry is utilized to bring a psychiatrist fully licensed, fully privileged in that hospital with knowledge of the state laws, which is very important so that everything is by the book and meets the requirements of the legal community, with an information flow pattern that allows the psychiatrist to understand what he or she is coming into, what the requirements are in that state, the staff to understand the responsibilities of that psychiatrist, provide the support necessary, and then an interaction with the patient. Really, the least problematic part of all of that, in our experience, and perhaps in others on the line, is really the interaction between psychiatrist and patient, which is typically quite well accepted by the patient, and in fact may be less threatening than a psychiatrist at the bedside. If we can move to the next slide. So what we're going to do now is just make a few remarks and really make some concluding remarks about what we've talked about. And then we're going to open the line up for questions. There is a mechanism within the webinar to ask your questions. The moderator will provide them to us, and we'll answer as many as we can in the time remaining. And then we will obviously also be available to you for contact after the webinar. We can move to the next slide. So in conclusion, the basic point to be made is that telepsychiatry, and in fact telemedicine, is not, shouldn't really be judged as particularly new or different. Telemedicine, in fact, has been practiced quite well and is published in the literature for the last 20, 30, 40 years, depending on the technology. The technology is only making that easier and really is only an enabler of the interaction between patient and provider, in this case, a psychiatrist. Now, the technology, which we have not really talked about very much, needs to be reliable, needs to meet HIPAA and high-tech standards, and needs to really facilitate that interaction without a glitch. It has to meet certain requirements. That's also an important part of engaging in your program, whether you develop your own program or engage an outside partner in those programs. The outcomes are clearly demonstrated in the literature to be better with telepsychiatry, certainly against standard care, and in fact are equivalent, in some cases better than on-site care. If it weren't for the patient outcome being better, we wouldn't talk about doing this, but it also improves the bottom line, as I talked about, related to bed availability, reimbursement, capacity, and all the markers that your CFO needs when you are going to your CFO and trying to make a case that this clinical need makes sense in your hospital setting. Board-certified, qualified psychiatrists available through telemedicine can enable your emergency department to evaluate patients quickly. That is a fairly broad statement, but it's the case. And psychiatrists have become quite comfortable in this realm and provide the care as well as or better than they do in a live setting. They will tell you, and data shows it, that they will sometimes even be able to spend longer with the patient in that sort of setting, in a more comfortable environment. They aren't the distractions of outside forces coming through the door, and there's not the concern about any intimidation in the room by either party, and so it's a very comfortable environment for those parties. Clearly, bringing help from outside when that help is not available improves the patient experience, the staff experience, by reducing wait times. This is, walking past a patient who's been in a bed for several days and wondering what is going to happen to that patient after they have been through 5 or 6 shift changes in the emergency department is an uncomfortable experience for everyone. This has financial and operational and clinical benefits that are calculable, but sometimes beyond calculation. And then it is very important that as you're developing these programs and as you're working with providers, you have a clear understanding of the changing in state regulations. States, state boards of medicine, state legislatures can be a bit behind the times at times, but in fact, some of them are being very forward-thinking. They now recognize, also in working with outside organizations like the American Telemedicine Association and some key psychiatric organizations, the APA, the AAEP, and others, that this is really an adjunct, and it's really beyond an adjunct. It's a normal part of medicine, and it's a way to get the proper care to the patient at the right time. So if we go to the next slide, and what you're going to see on the screen in front of you is really your action plan. The first thing to do, figure out what your situation is. Now, your data may be all over the place, and that was the primary result of the question number 2, is that, yes, you have the data, but it's in a lot of places. Go find it. As Hai said, go find the data and put it together in the best way possible. It is not going to be perfect. Don't wait for it to be perfect. Figure out your wait time, figure out your sitter time, and then go talk to your church nurses and your physicians and your social workers and get the real analytics of the problem. So if we can start taking questions now, this is really an action plan for you. And then once you get the data, you begin to look at how telepsychiatry, broadly defined and broadly applied, can really help your organization through its unique behavioral health challenges.
Great, thank you so much, Dr. Jolly. So attendees, like Dr. Jolly said, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. So please do send your questions, and we're going to dive right into the Q&A right now. So Dr. Jolly and Hi, some questions have rolled in so far. The first one is, what are the considerations regarding build versus buy? Hi, do you mind taking that one to get us started?
Yeah, sure. That's a really, interesting question. And I think the answer is that it depends, although there are certain key considerations that organizations should think about. First, and I would say they kind of fall into 5 different buckets, right? When you think about build versus buy, generally speaking, when you're looking to deploy a telemedicine program, first is time to market, right? And when we engage in conversations with a lot of folks, the number one challenge that most healthcare organizations have today is the bandwidth within the IT department, right? Generally, they have, good IT departments, but they've got, 140 projects in the queue. And, where does this fit? And how does it get done? And so, when we think about time to market, I always think about it in terms of opportunity cost, and that's the type of dialogue we engage in with a lot of organizations. Right? The second is execution risk. If you're looking to build it yourself versus a platform that's proven or tested, the question is, what are the integration risks? Best of breed sounds, like a great term until you have to try to cobble together a dozen best of breeds into a unified platform that's seamless to all the participants, the patients, the staff, the providers, and whatnot. That's the second bucket, we generally engage in. The third is kind of the upfront capital. What's the desire to make those investments, upfront versus leveraging a platform that's already built? And some hospitals have the capital and their desire to control the platform, but the vast majority of the time, there's not necessarily a hefty desire to deploy that capital upfront. And I think the fourth category kind of ties into that. It's not just the upfront capital, but what's the willingness to continue to invest in the platform? Because that's where the real hidden costs are, which is, you can stand up a program today, but the market's changing fairly rapidly. There are a lot of folks, out there, ourselves included, who are investing millions and millions and millions of dollars each year in R&D to enhance the platform and continuously improving the platform. And if you build it yourself, are you willing to do that? Or do you have partners who are willing to do that? And does their product roadmap align with yours, or even align with other of your partners, so that there's an integrated solution 5 years down the road? And then the last thing is more around kind of if you do it yourself, you're versus buying it. One of the advantages I have seen from buying it versus building it yourself is access to best practices. Right, there are folks who are out there serving a lot of peers, so your peer organization. They've seen lots of different iterations, lots of different use cases, a lot of different applications. And that insight is incredibly valuable because it can help you avoid a lot of pitfalls. I'll say for SOC, we're not perfect. We skinned our knees plenty over the years, but the nice part is that we've had, with the passage of time, we had the chance to course correct. And so when we partner with an organization, all that learning, all the school of hard knocks, all that accrues to the benefit of that partner. Because they don't have to go through it, for example, right? So those are the considerations when I think about build versus buy. Clearly, the benefits on the build side, at least from what I hear, is notion of control. But I think, you know, the discussion I always have around that is that real control or perceived control, or when you partner, or you find the right partner, don't you effectively have control without all the risks associated with building yourself, or the time to market challenges and all those things. So those are the elements of the discussion I typically engage in with a lot of our partners.
Okay, thanks, Hi. And as you were speaking, this question came in. This is for you as well, Hi. So I'm going to pose this your way, and then Dr. Jolly, some come in for you too. But Hi, if I buy, what are the things I should look for in a partner?
Yeah, I mean, you know, I think that, you know, to me, it's partner is one of the most abused term in business, as I like to say, right? Find somebody who's really a partner, who's not going to nickel and dime you, who's really going to bring true expertise to bear, who's going to bring forth a truly consultative approach, and that there's an aligned success model, right? And somebody who's lived and breathed it, right? There, you know, because, you know, a staffing company who happens to have, you know, physicians available for telemedicine consults, you know, they're not going to help you with the platform, per se, right? They don't understand the platform. They're not technologists. They understand that. Vice versa, on the other end of the spectrum, a pure play technology company has never really lived and breathed a consult, you know, around, you know, truly taking care of the patient in a high acuity environment where seconds matter, right? And so it's finding that partner that can really help you navigate, you know, both sides of the spectrum, so to speak, because at the end of the day, telemedicine does straddle both, right? It's not just technology, right? And it's not just staffing. It's the ability to the balance of technology and clinical insights.
Thank you, Hi. Dr. Jelly, this question is for you. Are there clinical limitations to telepsychiatry?
There are very few, really. Psychiatry is really a specialty based around talking with the patient. There is some physical exam involved. The clinical limitations are quite limited. There may be limitations just based on any disability of the patient, you know, simple things. But in fact, the limitations have mostly gone away. Providers and patients initially had some resistance to this as a method, wondering how it could be done remotely. But in fact, that's almost never a barrier. It really becomes a barrier of staff acceptance and staff understanding of how it works and what it can do. The legal barriers are also sort of going away. There are still some that we face in other space, but those are now being worked on and going away. But truly, clinically, the interaction is as good, if not better, via a telemedicine link, as long as that telemedicine link is set up in a reliable and dependable way.
And then how about the types of clinical or operational metrics people should track, Dr. Jolly? Do you have any insight on that?
Certainly. Those are metrics that we think about every day, and other providers do, and emergency department managers and hospital executives do every day. The clinical are really, first, the demographics of the patient population and identifying the problem. Once you've gathered the data on the problem you have, you want to look at that data and figure out what you're doing about it. The clinical metrics are also important related to the outcomes you're looking for, whether it be reversal of involuntary commitment, which is an important one to demonstrate value of your program, medication utilization, and repeat visits. These patients, many patient populations tend to come back to the emergency department. This is a population that really does in very high volume. One outcome metric in a local hospital might be repeat visits of those patients, because that could demonstrate effectiveness. As far as the operational metrics, you really want to watch your mechanical metrics, such as IT uptimes and communications issues, but also response times and those sorts of metrics to make sure that whatever system you're using is getting to the right patient at the right time.
Thanks, Dr. Jolly. Okay, let's see. Hi, this question came in for you. What have been the most challenging obstacles with a startup telepsych program in a hospital setting? So staff buy-in, resources, IT, any challenging obstacles you can share?
Yeah, sure. For us, we, as I mentioned, through experience, we're delivering our solutions, on a national basis with dozens and dozens of facilities today. So we've kind of seen it all. What we typically tell folks is that it's not so much a, there's two things I highlight. First is kind of pre-go live. The long pole in the tent is always licensing and credentialing when they're looking to, when partners are looking to access our physician network. Clearly, if they're looking to deploy their own psychiatrists on our platform, it's us helping them, share with them our experiences around how to appropriately license and privilege those providers across their enterprise. But that's typically the long pole in the tent in that it takes the longest time to make those physicians productive. But once it goes live, a lot of it's about workflow, right? It's about educating, the local staff not to do things as simple as stacking the patients, right? That as the patients come in, initiate that request for a teleconsultation, for a telepsychiatrist, as opposed to waiting for a batch, because that, from a workflow perspective, that's much more difficult to address from a staffing perspective. And so it's working the workflows, and it's continuous training, because there's generally pretty high levels of turnover within the ED. And as new staff comes in, there's a need to retrain them on the workflows. And so we're constantly monitoring the metrics to make sure that we're proactive in reaching out to our partners around that retraining, or asking them to inform us when that turnover occurs.
Okay, thank you so much. And this will be the final question of the webinar. So what is the typical workflow for connecting to a provider? How long is that wait? Dr. Jolly, do you mind taking that one?
We get asked this question a lot, and everybody has to consider how this is fundamentally how is it going to work. And really, it works just like having a local provider, except that there's a telemedicine system in the middle of it. A physician or provider at a local hospital recognizes that he or she needs a consultation in the acute care model. There are other models of this also in an outpatient setting or a post-acute setting, but in the hospital, physician or other provider recognizes they need a specialist, in this case, a psychiatrist. They contact a central access point either by phone or by increasingly an internet connection, as we've begun to develop, to try to take as many handoffs and human-to-human interactions out of this as possible to reduce errors, request a consultation just the same way that one does it now, and then a provider, appropriately licensed in the state, credentialed in that hospital, typically speaks with the local provider, and whichever provider knows the most about the patient, be that a nurse, a social worker, or a physician, to get some background information and a set of goals about the interaction that's going to happen, and then interacts with the patient, family, and others, either both by video and also by phone, sometimes remotely, to figure out what the exact total situation is, then interacts with the provider again to agree on a disposition, the right thing for the patient. We typically get to see these patients within less than an hour, but obviously there needs to be an interactive process to govern things like severity of illness, when there are children involved, when there are restraints involved, when there's a danger to staff involved, to try to improve that interaction, and that's what the communications technologies are for.
Great. Well, thank you both for an excellent presentation, Dr. Jolly and Hai. That concludes today's webinar. Thank you to the attendees who joined us today. We hope to have you back for future webinars.